Hello. Great. Wonderful. Right. I think we'll go ahead and get started so we can stay on time. Thank you guys for coming to the HPBA ASTS Symposium, where we're going to talk about advanced hepatic cholangiocarcinoma and options for treatment. Today we're looking forward to getting started. This is Zalami from Nova Health, who's going to talk about the surgical oncology perspective. Session. I'll be sharing my perspective on surgical oncology with the advances of treatment for hepatic cholangiocarcinoma. I have no disclosures. I don't know where the AV is. Thank you. Give it a minute. Okay, I'll just be turning my neck a lot, but that's okay. All right, well, so today's objectives of this talk will be discussing the systemic therapies and outcomes for patients with intrahepatic cholangiocarcinoma. I'll then be discussing the role for HAI therapy for intrahepatic cholangiocarcinoma, and I hope to show you just like where the field is going with future directions and ongoing clinical trials. So I think just for the focus again, we will be discussing intrahepatic cholangiocarcinoma as a focus. Specifically, we're focusing on locally advanced disease for this session. In general, the standards of care is systemic plus or minus local regional therapy. And I would like to highlight that, there has been some evidence of the role of HAI therapy, which we'll go into today. And as always, I'd like to state that episode. So that's what I do. Let's get into it. We talk about hepatic cholangiocarcinoma without discussing the role of molecular profiling, which has really been increased and very relevant to the therapeutic approaches we have, with up to 40% of patients having attributable genomic alterations. Most common alterations are FGFR1 through 3, patients that receive followed by IDH1 and 2. We also have the rare that was BRAF and HER2, which also can be targeted and have better outcomes. And there's always anti-tumors with this specific subtype of the cell group. So obviously, the exciting slides to show is that we, for the longest time and over a decade ago, we had nothing that the first-line therapy was based on the ABCA2 trial. Like after that, we had the introduction of pembrolizumab, or MSI or high reduced burden. But I think in the last 5 years, we had the introduction of targeted therapies, which really started in with pemigatinib as the first FDA approved that, and then followed by various other FGFR targeted agents. And now, obviously, with the RAS, but now at least like TOPA study, which was the first that immunotherapy for the combination of gemcitabine and Durvalumab, which was positive back then, and it's now also considered the same type of population with carcinoma. Just for the targeted action, we're starting with the first drug that was approved with pemigatinib, which is an FGFR going to and expected to inhibitor. This is a specific trial beside 202 that looks like the first cohort was the ones with FGFR2, this is other FGFR rearrangement, and then the third group was patients who had no FGFR alterations at all. And as you can see, that the overall response is the primary endpoint. On the right plots, you see that the overall response rate was significantly higher in those with the FGFR fusion with cohort A. showing essentially the median PFS of almost 7 months compared to like 1 or 2 months in the other cohorts. So with that, this led to the approval of pemigatinib. That's a really targeted therapy that we can't forget to talk about the IDH1 and IDH2. This is a study that looked at essentially a randomized control to look at envudeucitinib with placebo in patients with allowing for crossover. Patients with either locally advanced disease, metastatic cholangiocarcinoma, and then also prior treatment of at least 1 to 2 lines. And I think actually before that, I would like to show that about 700 patients had to be screened here, and this took several countries and several, like almost 50 sites. So I think it just really goes to show like how difficult and challenging it is to really like get a small number of patients even like recruited into these trials. It really speaks to the heterogeneity of this disease. So that we're going over like all the details of the patient cohorts, but you can see that the survival here to receive the treatment, this is placebo was pretty significantly longer. Before even into the overall survival rate, even though the intensity analysis is not significantly positive, if we actually were to look at the rank preservation failure time, it really allows for those patients who were crossed over to not be included as that, and pretending that had not crossed over, the overall survival rates would have been actually significant in this trial. So that led to the approval of this drug for those patient cohorts. Besides the one the study with or high TMBI tumors, we now also have, as I mentioned, with the COPA study that was presented last year, considering durvalumab as the first-line treatment for NCCN guidelines. Now let's talk about some regional therapies. I'm just going to basically go over why do we use HAI therapy for patients with intrahepatic cholangiocarcinoma? The reason that there's a large group of patients that present with locally advanced disease, however, without any metastatic sites. We know that the majority of these occurrences occur within the liver. Furthermore, we know that if you control the liver disease, that control have better oncologic outcomes. We know that this tumor derived their blood supply from the hepatic artery. So we really exploit the hepatic artery infusion system, use FPBR, which is an analog to 5-FU, and has been shown to have efficacy in intrahepatic cholangiocarcinoma. So the outcomes with that, this is the very first study that came out with a retrospective analysis from a patient cohort with unresectable disease that were treated at Memorial Sloan Kettering. 236 patients overall that were unaffected, but looking at a specific subset of 167 patients that had liver-only disease, they looked at some patients who had systemic alone. Yeah, the waterfall type that the response rate for systemic alone was almost 10% compared to the response rate of patients who had HAI therapy, almost 2%. 8 of these patients out of the 769 were converted to recipients, and the patients with the liver-only disease showed a significant improvement in their overall survival, comparing those who had the pump versus systemic therapy only. This naturally led to a phase 2 trial, again out of Memorial, using GEMOX as the systemic therapy with HAI. And this was a single center study with 38 patients. Looking again at the response rates, almost 60% achieved a partial radiologic response. Like reportedly 18 months, 11 months, and the median overall survival was 25 months. So again, this is a single study, but I think if you were to continue this is a really promising outcomes that we have. This is really interesting and led to this mostly institutional randomized controlled trial that is NIH funded by various sites that are listed on the left there. And I think the really most exciting part of this study to me is really all the variables that included looking at alterations, genomics, is really to define new biomarkers in this patient. They hopefully improve outcomes as well, or like hypothesis generating like new ideas. Last, I would like to mention in the HBC in the US that is currently under its way. And I believe last I had an update was about 6 patients enrolled. This is a small study with a big grouping using really modified performance as a green direction to them to the API and with unresectable disease. So it'd be really exciting to see what these outcomes were to come with that. And I think in the future, I just want to really point out that with everything else, we're kind of moving more and more forward with combination therapies and also in the neoadjuvant space. So this slide is just to show you like really three. When I did a search, I came across like over 60 clinical trials that are currently ongoing in this space that are even active. So various studies and looking really at different combination of YNN plus or minus systemic based augmenting therapies as combinations for patients with locally advanced disease. Really exciting time, and I think even though it's not no section on resectable disease, we're seeing just more and more that this is moving more than advanced that they're using the idea of treating these patients early on, even with resectable disease. So I just want to thank again the organization for including me and take any questions.
Next speaker is making the rounds this meeting about this topic. So we're privileged to have Gonzalez Apsochin from Toronto talk today about transplant selection criteria for intrahepatic cholangio, and particularly the question of disease stability and how that factors in. So thanks, Gonzalez.
Thanks for the and it's a pleasure to be here. So I think if I can get my slides, please. In the next 10 minutes, I'll try and discuss a little bit where we stand with transplantation for intrahepatic cholangiocarcinoma. That is indeed a very controversial indication, and see if there's some patients that may benefit from this therapy. All right, we still don't have the screen here. Nope. Okay. So these are my disclosures. I think the most one of the things I would like to start to do, since to divide my talk, is to separate intrahepatic cholangiocarcinoma that we're diagnosing on cirrhotic patients. So these are cirrhotic patients that will be followed by our, some of our hepatology colleagues that are here. There's a nodule in the liver that doesn't look like HCC, a biopsy is done and a diagnosis of adenocarcinoma is made. And I think it's a very different scenario than these large, mass-forming tumors, many times multifocal, that usually happen in healthy individuals with healthy liver, with no liver disease. And I think we need to distinguish between these two populations. So let's start talking about intrahepatic cholangiocarcinoma in cirrhotic patients. So as many of you know, liver transplantation has historically been contraindicated for patients with intrahepatic cholangiocarcinoma. And the reason being is because the outcomes for these patients historically were very poor. We're talking about patients that had 5-year survivals in the 20%. And actually, if we think about the early days of transplants, Starzl, I think out of the first 8 or 9 transplants that he did, 1 or 2 were actually bile duct cancers, and the outcomes were very poor. I think one of the problems we had with the data at the time is that most studies, due to the small number of patients, combine patients with cirrhosis, no cirrhosis, combine patients with hilar cholangiocarcinoma, intrahepatic cholangiocarcinoma. And I think we need to distinct in some of these entities. So some years ago, we put together a study where we looked at patients that were transplanted for hepatocellular carcinoma, and were found to have intrahepatic cholangiocarcinoma in the explant. So these were patients that were misdiagnosed for HCC, and we actually were able to define the very early intrahepatic cholangiocarcinoma, like the very early HCC, in patients that had single small tumors that could have very good outcomes after transplant. As you can see, the 5-year survival for those patients with small intrahepatic cholangio was very good. However, as you can imagine, this was a very small study that needed some validation. We went ahead and did a multi-center study. It was an international multi-center validation study where we were able to do, a similar analysis. So we looked at patients that were misdiagnosed with HCC and actually had intrahepatic cholangiocarcinoma in the explant. And again, we were able to define a small population of patients that actually did pretty well with transplant, meaning they had a 5-year survival around 65%, over 65% with a low recurrence risk. Others have, mimicked these studies, and actually, this is a very interesting study from the Purpose Hospital in Paris that actually challenges the idea of very early intrahepatic cholangiocarcinoma and looks at patients that had tumors up to 5 centimeters, and argues that maybe the very early intrahepatic cholangiocarcinoma for transplant can be patients that have single tumors up to 5 centimeters, and that's what they showed in this study, where they took the patients, with tumors up to 2 centimeters. And more than 2 centimeters, but less than 5, and actually the outcomes were similar when you look at disease-free survival and overall survival after transplant. Some of the authors are here in the audience that looked at, a large database in the US. The data obviously is not very granular, but again, showing those patients with very early cholangio and with single tumor present 2 centimeters have a very good outcome after. Because that's trying to collect patients and have disease, challenging to accrue, and there's many challenges for this trial. The main one is that it's hard to identify these patients pre-transplant. Carcinoma. What do you do with a patient that has a small, let's say, 1.8 centimeter cholangio, this is that, we would challenges on the trial. However, I think the data available from some of other studies and some of other studies, the American Association for the Study of the Liver actually came up with this algorithm in their guidelines, PSC and cholangiocarcinoma guidelines, where this possibility is included in their guidelines, and soon the International Liver Cancer Association guidelines for cholangiocarcinoma will be out too, with similar concept that in patients with single cholangiocarcinoma less than 2 centimeters, obviously always with no extrahepatic disease, transplantation may be an option. So I'm going to move on to what I think is a separate population. So these are, again, as I mentioned, large intrahepatic cholangiocarcinomas, multifocal disease. Is this combined effect between inflammation and methadone, which is a patient who had liver disease or liver-only disease biopsy intrahepatic cholangiocarcinoma. They had no limitation in size and number of tumors. However, they had to be stable for at least 6 months. Most of them actually were stable for way longer. They these patients quickly, and those that were very stable actually underwent transplant. And when you look at the first, iteration of the paper, we put several patients in the waiting list. Paper they described 6 patients. Then they had data for 12. I'll show you some of their latest data. We've actually transplanted 18 patients with intrahepatic cholangiocarcinoma. At least these are the publications. I think right now I think they've transplanted over 20 patients. And to recognize that these are locally advanced tumors. So as you can see in this, if you look at the median size of the tumor, 7.4 centimeters, most of the patients had multifocal disease. So we're talking about large, mainly multifocal intrahepatic cholangiocarcinoma that were responding on chemotherapy. This is the latest study where you look at the patients that were potentially eligible, the different reasons for to exclude them from the trial, and then they ended up transplanting, or at least publishing 18 patients that were transplanted and 14 that were not. This is not randomized data. This has a bunch of selection bias, and I think it's important to point that out. But these are the outcomes. The 5-year survival for those patients that got transplanted was around 59% of 50% disease-free survival. Again, this is not randomized data, and obviously, there's an important selection bias. But just to start looking at what is the path for some of these patients, and I think some can actually do relatively well. I want to point out, just So good. I like angio. Actually, one of the is better than using chemotherapy. That's obviously and opinion. The problem with the method of evaluation trial is that a lot of to real one of the issues with the method of trial is that it's not clear which which patient has to local therapies, which systemic targeted therapies, no targeted therapies. I think it's going to be very important genetic determinants to looking at different markers and policy and the answer to I think there's a lot of them to do like solutions. I'm going to go through this if a good job, and I think it was this is a slide and many of them have ideal presentations, which is fusion, etc. So it's again, these are selected group of patients, and maybe that is the way we're going to be selected. This is a patient with a large so this patient could undergo an patient will get a patient with some sort of I think that's well. I think this is wishful thinking today, but I think that will be another tool to select the changes in the circulating this is together and selection criteria. So to finalize, transplantation today for cirrhotic patients with intrahepatic or single intrahepatic cholangiocarcinoma less than 3 centimeters provides good outcomes. I think we need data from prospective studies, but I think now we're seeing retrospective data. We have a patient with a small tumor and a cirrhotic patient, every outcome is very good with transplant. I think the large multifocal, likely increases overall survival. I think the plan is that we have high recurrence rate. And I think we need better biomarkers and better therapies to improve patients. Long
Thanks. Next, we have Samira Ilyas from Mayo Clinic, who's going to talk with us about sort of pre and post transplant management of patients with intrahepatic angioma.
Good afternoon, everyone, and I would like to thank the organizers for the opportunity to speak. And I would like to thank Dr. Seppi Susan for providing the rationale for intrahepatic carcinoma. These are my disclosures. And so since he has provided the rationale for why we should be continuing the intrahepatic carcinoma, I really go into what we should be doing with these patients. We identify the patients that we for those that how do we treat that patient? What is the symptom with that? What is the neoadjuvant treatment options and surveillance pre and post transplant? also, I think that as this is another thing that has nicely outlined, we really need to start thinking of these two separate scenarios. These are separate disease entities. You have liver cancer, tumors in a unresectable due to the underlying liver dysfunction versus larger tumors, multifocal disease that is clinically irresectable. So I'll go over the management options reinforced by both. Carcinoma, the small tumors occurring in cirrhotics, is gaining mainstream acceptance. As I pointed out, this is but clearly reflecting or the AASLD guidelines that were just published in February incorporates and will also be incorporated into the forthcoming EASL or European guidelines. And so, in terms of it's widespread intrahepatic carcinoma in the setting of cirrhosis, unresectable, primarily due to underlying liver dysfunction. And so, in terms of some of the exclusion criteria in the ensuing slides, I'll provide rationale for why we chose some of these criteria. So single lesion less than or equal to 3 centimeters in diameter. As you saw, the international study, very early in hepatic angiocarcinoma was defined as a single lesion less than or equal to 2 centimeters. So I'll give the rationale for why we chose this cutoff. No microvascular invasion or poorly differentiated pathology, and there's data to support this as well that I'll go over. Vascular invasion, extrahepatic disease, a no attempted research for violation of the pain, and of course must otherwise be a good candidate for treatment. The research we decided work very early that multinational study. This is a carcinoma, which is greater than 2 centimeters, or multiple tumors. And the survival was 65% in the very early group, equal to 45% 5-year survival for the advanced group. Stage patients who had tumors that were 2.1 in size, moderately differentiated histology, and their 5-year survival was comparable at 51%. Very early that had a 5-year survival of 50%. So this is a rationale for choosing the 2 centimeter count. Microvascular invasion and differentiated pathology risk differentiation was available. Centimeters. We had well-developed pathology, their 5-year survival was 5% compared to 17% for differentiated histology. And so I really think that histology matters, and it should be inclusion criteria for this has really differentiated histology. Resection, tumor size was 5 centimeters. And the 5-year survival for the patients that got undergone liver transplant was 5%. And so perhaps we should be thinking of increasing the size. And the reason to do that is it was really difficult to enroll patients into these post-really intrahepatic angiocarcinoma because it's hard to find patients that have small tumors. Particularly if the tumors are 2 centimeters or less, because they're often not biopsied, and rather than going through burns, that we often wait until Imaging of course is feasible and throughout the contract laboratory evaluation markers. Part of to exclude lymph node metastases and standard limit evaluation. Adjuvant treatment. These are very similar to a blood is particularly radiofrequency pollution of probably buying in terms of how data. I know that the data is limited to what we can observe with hepatocellular carcinoma. And recurrence more than a year. One of the bigger challenges that we have and alternative as surveillance functional imaging in lab, including every 3 months. The way to execute is living but evaluation. Every 3 to 4 months, every 6 months until year 3, and annually, but we stopped at year 5. We're just starting to talk about, and I think we have well-defined profiles. Focus on, that now, the patient had prior resection, and other kids had treatment and trying to design a protocol because it's really works, right? treatment, it's difficult to calculate that in the sense that it's interested in developing a protocol for liver-limited lymphatic carcinoma. I think that turned out we would struggle a little bit. There's a paucity of data in terms of neoadjuvant treatment for lymphatic carcinoma. And so I think the best data, you know, I think has to be rigorous. It has to be based on the best available data. What I think the patient looks like and what's the last name of it. So, that supports this. It's very fascinating for the presence of metastatic disease. Evidence of hepatic disease, evidence of other cancer indications of treatment. Evaluation, in addition to what I mentioned earlier, hepatic cancer carcinoma, cancer data why this should be part of the evaluation. All of this is collaborated in subsequent as well, that patients who have carcinoma have higher median CA19 levels than those who have disease. Moreover, patients who have previously disease or receivable disease lower median CA19 compared to those with advanced disease that is unresectable. And this particular study, that was less than 5%. It's very interesting for the presence of so another reason for the CA19 to be elevated because that's something that we encounter frequently with carcinoma. It's for the carcinoma. That analysis measure, and it's demonstrated that although diagnostic accuracy, so that's really more specific to diagnostic as well as which is highly concerning for metastatic metastases. Multifocal disease have a much better survival compared to those who have liver metastases. Multifocal disease is by definition hepatic carcinoma with liver metastases. And population, there's significant risk from metastatic disease. And in the line of treatment, that's even more concerning, right? Because if there's any micrometastatic disease, then after treatment, the robust venous infection is passing entity. But very careful that these patients are very true. The slide earlier from the Semester group that had utilized a number of different treatment options. I think that the best data that we have, so we should complete with multifocal disease, which is intrahepatic metastases, similar to those with advanced PCA. Standard of care therapy for patients with advanced PCA is gemcitabine. Based on one study, we saw that earlier. So the neoadjuvant treatment I would propose should be this because when you bigger, you have to get one standardized treatment to return. Areas we don't impact. numbers are small, so to learn anything, you need to be very structured. We need a washout period. So probably around 4 weeks about the inhibitor mediated allograft rejection. About early it's easier to follow 1, 2 lines there's decrease in size. Here you're if there's multifocal disease, one somebody's inside, another is decreasing, and maybe challenging us with to be eventually using standard criteria. Similar to what we were doing. The use of what I wanted to point out was the data that we have available. So looking ahead, we have not only to identify potential candidates and targeted therapies, but also in terms of survival. We know that given centers have a indolent disease course as opposed to given worse outcome. And in terms of technologies
It's a great talk. We're going to shift gears in these next 2 talks to set up the discussion well. I think we're going to talk a little bit about the ethics and logistics of how we could potentially transplant patients with this disease. And Angie Wall has agreed to join us today to talk about the ethics of living donation for advanced cancers in general, and hopefully provide us with some principles we can apply to this discussion.
All right. First off, thank you, Leanne, for inviting me. I'm really excited to talk to you all today. I'm Angie Wall. I'm from Baylor in Dallas. I don't have any disclosures other than that I'm a transplant surgeon and a bioethicist. So I am not. I'm not going to talk about a lot of data because you guys know it better than I do. So. What I'm going to do today is I'm going to set up the framework for how we can think about living donation in the setting of advanced cancer. And in particular, I'm going to explain why we in general do not use living donor liver transplantation for advanced cancer outside of UNOS criteria. Second, I'm going to describe how our mental models impact the way that we view living donor liver transplantation. And then I'm going to talk about how we can actually reframe our mental models to where we can think about living donor liver transplantation differently in the setting of advanced cancer. And again, I'm going to do it in 10 minutes with no data. So let's go ahead and get started. So this is the first really important thing. The way that we make decisions is important. So the way that we make decisions is we have a problem, we make a decision, we have a result that feeds back into the next time we have a problem, we make a similar decision, we have a result, keeps feeding back. But we don't make decisions in a vacuum. And the way that we actually make decisions is that we have mental models, that we have decision-making rules in our head that then drive the decisions that we make. And every time we make that same decision, it reinforces the mental model, and we have this cycle that happens over and over again. And why this is important is that mental models are specific processes that you use to examine a problem. So this is a problem well outside of anything that we do. But for anyone who's read Thinking Fast and Slow, this is one of the mental models that is described in this book. So the question, the problem, how do we protect fighter pilots? This was a study from World War II. The answer is, let's determine where the planes incur damage, and then let's reinforce where the planes incur damage. So the mental model that's described here is something called survivorship bias. So what happens is we look at the planes that come back, the planes that made it back to base, and say, well, let's reinforce where they all got shot, because that's where they're commonly getting shot, right? We look at what we see. But the problem is that if you look at what you see, you forget about those who don't survive. So it's likely that the strikes on these planes that didn't come back were in the completely different location than the strikes on the planes that did come back. And so if we use a survivorship mental model, we don't think about the people, about what we don't see. And so there's a blind spot in using mental models. And so that's what I'm going to talk about. Where is our blind spot in using mental models for living donor liver transplantation? So again, problem, decision, result. This is where ethics comes in. An ethical framework is a mental model, and it's based on philosophical theories, first principles. And we use ethical frameworks all the time when we think about what we do in medicine. So the one thing that we have to think about is that when we have a counterfactual scenario, that feeds back into our mental model for ethical frameworks. And it is really important to consider when we have counterfactual scenarios if our ethical framework really fits the problem that we're trying to solve. So I can keep moving. Okay, so let's start with liver transplant, because this is what I know better than surgical oncology. So with liver transplant, our mental model is based on the most common scenario. The most common scenario is deceased donor liver transplantation. The context is that we have limited grafts for transplantation, so we have to fairly allocate those grafts. And the underlying motivation is that we need to be good stewards of organs for transplantation. That's the transplant mental model. And if you take that mental model and you think about the underlying principles, their utility and justice, we want to maximize the net amount of overall good, we want to have great outcomes, and we want to be fair in the distribution of these organs. So living donor liver transplantation is housed in liver transplantation, right? It's housed both clinical and regulatory infrastructure of transplantation. So if you take the liver transplant mental model and you apply the first principles, which are equity and justice, then you think about the problem of living donor liver transplantation in a particular way. So the problem is, or the way that the problem is framed is advanced cancer an acceptable indication for living donor liver transplantation? The decision is that it's not good stewardship of liver grafts, right? These grafts may have worse outcomes. You don't have as long graft and patient survival. And then the decision is that we shouldn't do living donor liver transplantation for advanced cancer. But the problem with this is that your counterfactual scenario is different from a regular transplant, right? From standard deceased donor transplantation. And it's that living donor grafts are not limited resources, and they're not public resources in the same way that deceased donor grafts are limited resources. So we can think about an oncology mental model instead, right? So with surgical oncology, or with oncology in general, and this is my interpretation, so please bear with me. Your most common scenario with advanced cancer is that you want to utilize aggressive treatments, and you're okay with high risk and marginal benefits, because that's, there are some patients that you're willing to push the limits on. The context is that there's a willingness to explore avenues of treatment when patients want to be aggressive in their fight against cancer. And the underlying motivation is that cancer sucks, right? And that we should entertain all available options to increase the quantity and quality of life of that patient in front of us who has an advanced cancer. So let's take the oncology mental model. This is a fighter mentality, nothing to lose in being aggressive, right? And so if you ask a question, if you set up the problem in a different way and you say, does living donor liver transplantation provide a survival advantage for advanced cancer? And then your decision is, well, if it's a better survival for patients than our alternatives, then we should do living donor liver transplantation for advanced cancer. Now, the problem with using a strictly oncology mental model is that the survival advantage isn't applicable only to the individual patient, because you still have a transplant center risk threshold, and you still have a living donor with a risk threshold. And so if you add one more piece to a mental model for oncology, what you can do is you can kind of create some boundaries. So this concept of a willingness to transplant threshold is kind of hard to explain. And this is something that this was a study that I did at Stanford on kidney transplantation for simultaneous liver kidney for SLK. So using a kidney for SLK. And basically what a willingness to transplant threshold does is it's an economic model for when we would be comfortable utilizing an organ for transplantation based on different scenarios. And it assesses the acceptable outcomes in terms of life years and quality of life years. So the more life years and quality of life years that you expect from transplantation, the higher your threshold is to choose transplantation as an option. And so you can think about a willingness to transplant threshold at both a transplant center level. So what is our threshold for outcomes? And then at an individual donor level, what is the donor's threshold for comfort in terms of expected outcomes for their recipient? So then if we put all these things together, we can have a transplant oncology mental model. So our principles kind of meld both together, and we have a patient-centered decision that has guardrails with a willingness to transplant threshold and really focuses on donor autonomy. It informs the donor about the potential outcome of the recipient in a more personalized way, not general outcomes of living donor liver transplantation, but more what we expect the individual patient's outcomes to be. And if we do that, then the question becomes, is living donor liver transplantation an option for my patient with advanced cancer? If the risk is acceptable and the donor is appropriately informed, then we should do living donor liver transplantation for this patient with advanced cancer. And so I think that that's a way that we can kind of meld our two specialties together and come up with a path forward to thinking about how to do living donor liver transplant, or why we would do living donor liver transplantation for advanced cancer. And so my final thoughts are, when we have new indications for liver transplantation, our standard mental models may not be sufficient. Breaking free of these models is not easy, because every time we talk about this, it comes down to, are we being good stewards of these organs? And the problem, and the elephant in the room that I can't talk about in the next 40 seconds, is that we can't change the clinical mental model for living donor liver transplantation without changing the regulatory environment. And that is going to be key to being able to move forward. So with that, thank you.
Thank you so much, Angie. Our final talk before we get to some case presentations is from Wellington and Andres from São Paulo University, and he's going to talk about some frameworks for how we should allocate deceased donor livers and think about potentially some tracking of our outcomes in a more international framework.
Thank you for the introduction. I would like to thank the organizing committee for the kind invitation. I'm going to talk about should we allocate deceased donors and how we could do it. I have more disclosures. And the first is how we can get out from this vicious cycle. We will have to start in one of these points and to change it. The question is, now, is it the time to allow the DLT for intrahepatic cholangiocarcinoma? The answer, I think, is yes. And here, DLT is an option, but in our reality, the number of DLT is too small. You can see, for example, is only 6%. So not all recipients have living donor available. In Latin America, the scenario is even worse. Distinctions is that the number of these donors is year by year. In the first year, it's around 60%. Donors, micrografts, etc.
like in the last 10 years, it's much to is doing and if you look at the population, it's much smaller than the treatment growth. This is another one. Also, other argument that we have effective treatment for hepatitis. The number of viruses in the waiting list. Is the survival of the transplant not yourself. We had like a survival rate 5% serious. They serious. They have good results. 11% of survival. Most recent series, 5 years survival rate, 16 to 80%. So it's good. And we consider 50% 5 years survival as a target. That is 70%. So already allowed. Life is true. Percentage of the survival, 68 years old cirrhotic patient with an expectation of 70% of their survival. Which one you should choose? This is a discussion. They have the treatable tumors. HCC. The incidence is only 0.5 to 2. 100,000. At most, 70% is incompatible to the time. Choose a lot of cues. It's two persons. This is not a long fact. If you take out as an example, the law that was introduced in the US in 2002, initially in urine bacteria, so it's done differently in each country. In US, it's the It's reality. That's why the data and the results. It's interesting. You can see here. And if we compare cholangiocarcinoma with HCC, here the cholangio is a more aggressive tumor, and based on what dropout so a suggestion or a proposal is that intrahepatic cholangiocarcinoma have an exceptional amount of impact. And this is adapted for each country. This process 4 to 6 months after the patient is accepted in eligibility criteria. Like I want to tell you what use like the energy to the liver. This was this. Okay, so you can see it's a huge central lesion with multiple nodules over the liver, and the tumor was invading the collarbone. From this of the collarbone, right over. Believe it's implanted on this new collarbone with the fusion. So this is the patient. First after the treatment follow-up with all kinds of appearance. This is the message. Should start the BLT rotation for intrahepatic cholangiocarcinoma in order to turn this vicious cycle to into a virtuous cycle. Consensus in eligibility criteria. We should do exception for the region. This was a very good initiative from the Toronto Center. Our center is also it's
We do have some case presentations, but our time is getting short, so we thought there's a lot to discuss, so we can maybe open up some discussion if people had questions.
Maybe while people are coming to the microphone, I maybe ask Gonzalo and Samara, based on the last two talks, what do you think is the right pathway to get to deceased donor allocation for advanced cancers like this, kind of using Angie's framework and Wellington's kind of perspective? Do you have thoughts on that?
You can go. Samara will go first.
I think that in terms of deceased donor allocation, and these are conversations we've had too, right? So mild exception points. I think we're probably closer for early intrahepatic cholangiocarcinoma than we are for liver limited. I think we absolutely need more data. For liver limited, as I indicated, we need rigorous protocols. So other centers that want to start doing that, they know exactly what to do. But for liver limited, there's been now, it's all retrospective granted, and it's for early intrahepatic cholangiocarcinoma. The studies are all retrospective, but in aggregate, they're all pointing to a very similar a really good 5-year survival. And so I don't know if we'll ever have enough prospective numbers, right? Because we don't have a way to execute these protocols. We're asking everybody to have living donors available. And so, it may be that we just have to pull together the retrospective data and try to make a case and make a push for exception points for that scenario. But for liver limited, I don't think we're there yet.
Yeah, if I can, a couple of things. I think obviously, we talk about the US, but this really depends on jurisdictions where in the world. I mean, I come from Spain where centers are having 3-day waiting time now. There's an excess of livers. This happens in Norway. So I think it depends on the jurisdictions. And I hear from American colleagues, and Shimon from Common, he mentioned that there's so many livers, and I think we will do so many livers that don't get used here in the US that may be used for some of these protocols. And I think that's been done in some countries, and I know it's challenging, but we were able to do it in Canada with the small intrahepatics, is to save, 5% of the livers in the country for protocols. And they do that in Italy, for example. So I think that may be ways to be able to access some of these deceased donors for some of these protocols. I mean, I am a true proponent of living donation in this setting for many reasons, and maybe we can discuss that later. But I think, there's definitely a risk for the donor. There's no question. But there's also a great advantage for the recipient. And at the end of the day, many of these donors are actually, they're obviously doing this for the recipient. And when you ask the donors, there's no question what the donors want to do.
So my question is on the ethics of live donor liver transplantation. So thank you. We talk about justice and we talk about disparities. And my concern is the patient who's been told, we can do it, but we can only do it by live donor, and they can't find a live donor. And the mental anguish of that and the ethics of that. So I think that also has to be brought into the equation for sure.
So I agree entirely, and we face that problem. So I think there is definitely an ethical issue there. I just think that if that may be the path to demonstrate better outcomes and then open up to deceased donors, but I'm willing to find a population of organs that we can use for some of these patients. But we struggle with that issue 100%. So I agree.
Chapman, St. Louis. I would like just to get the opinion and reinforce the issue that you mentioned that we have a lot of donor grafts that are not being used in this country. 10% of recovered livers intended for transplant are discarded. A third of our donors, and what the donors that have any organ recovered, almost always the liver is most likely to be usable than the thoracic organs and even kidneys in older donors. But a third don't have liver recovery today. And that's actually increased under broad allocation. Schimmel's groups talked about the late declines. We'll talk later today. There's a session on how to find more donor organs. We reported a few months ago and is accepted for publication a trial looking at livers intended to be discarded, machine perfused, and then transplanted. And we've done that now in 18 patients. 80% are for malignancy, for which the patient wouldn't otherwise be able to get a transplant. So, and the majority of those are for intrahepatic cholangio. I think the living donor discussion is an important one, but this is not the only way to get those patients transplanted. Finally, a challenge we face all regulatory bodies say we've got to access more donor organs, but our metrics are getting increasingly more stringent. So when you start having more marginal organs, you have more deaths. You face your center being under scrutiny that would never happen in the non-transplant setting. So anyway, Manji, maybe you can tell us something about the ethics of this dilemma.
That's a lot of questions all at once. I will say my charge was to talk about living donor liver transplantation, but I fully agree that there is a place for deceased donor liver transplantation as well. But the issue is again with the fact that you're still taking a risk on these recipients that is higher than the risk of most of your other recipients. And so let's say you do 10% of your livers as these discarded livers, and the expected 1-year survival of the patients that you are transplanting is 60%. Then you have to have 100% post-transplant, 1-year post-transplant survival of every other liver transplant that you do, because otherwise your center is going to end up getting cited. So every patient that you take additional risk on, you have to mitigate that risk somewhere else. And I think that is a huge barrier for us to push the utilization of deceased donor grafts for these extended circumstances.
Shimal Shah, Cincinnati. Since Chris doesn't get to do his case presentations, I was wondering if I can just talk about one case, and I have a question. We've done 2 cases of intrahepatic cholangio through the strict protocol that Methodist has out there, and we had a lady that was about 45, it had been about 1.5 years on chemotherapy, stable disease, but the liver was chock full of tumor, but everything was stable. CA19-9 was normal. We took her to the OR about 3 weeks ago for a deceased donor transplant, a liver no one else wanted to use. And we did the portal dissection first. And I didn't do the portal dissection, my fellow did it, but really just not many nodes, but about 4 or 5. And there was a tiny, tiny speck of micrometastatic lymph node positive. And she thought it might be a little lymph node right near the gallbladder area. The cholecystectomy had been done about 5 years ago, so there was no gallbladder currently. I hemmed and hawed. I wanted to do the transplant, but I didn't. So a question for so many experts on the podium, did I make the right decision? Second question for Gonzalo and others is 2-centimeter tumor. You think it's HCC, but your radiologist says, well, it might be HCC, it might be cholangio. So you biopsy it and it's mixed. Do I treat it like a cholangio or do I treat it like an HCC? Thanks.
Do you want to take the first? I can take the first one.
You want to take the first one? Sure.
Yeah, the right decision.
You can address your response to UNOS because Shimal's going to.
So in terms of the question of did you make the right decision? Well, time will tell, right? We don't have a crystal ball, but I'll tell you that we were in a similar scenario last month. Made the opposite decision, not to proceed. Tiny speck of was an intrahepatic early, very young patient, 25-year-old. We decided not to proceed because it's there's disease outside the liver, right? And what happens to disease outside the liver in the post-transplant, it just absolutely blossoms. We've seen it time and time again. And so I think it's a huge, huge risk. And so that was our rationale. I'm not saying you made the wrong call. I'm just our rationale for why we did something different, because it's not a typical oncologic scenario, right? Post-transplant is just an absolutely different realm and it has to be treated as such. You can take this.
Yeah, I mean, I'll just answer to your case. In our center, the way we do this, and maybe right or wrong, and time will tell, is that we do exploratory programming a week before, and that's one of the advantages that we talk about living donation, and we have not proceeded with a positive lymph node. To answer the mixed one, so I think if you look at doing it on a trial, the reason we decided to exclude mixed on a study is because we want to learn, and if you start including cholangios, mixed, etc., then you don't learn anything. But clinically, I think there's enough data to show that actually the single mixed tumors less than 5 centimeters, less than 2 centimeters actually do pretty well. I think we published this, I think the group of Magella have published this, so I think not in a clinical, like from a clinical standpoint, I would really treat that patient with ablation and transplant the patient.
That's the same way we handle it. And I think we do pump the brakes a little bit. Like we tend to observe those patients a little bit longer, but we treat them more like HCC with cholangio. Yes, sir.
Oscar Koerkamp from the Netherlands. Thank you for great presentations. Really impressive. I think this symposium was strategically scheduled while all the American hype chemotherapy surgeons are in another room. As a memorial fellow, I kind of feel I have to defend the pump a little bit. So one of my questions is, so if I understand correctly, both the Mayo and Toronto, huge procedure centers, but you transplant about 1 patient a year for advanced intrahepatic cholangiocarcinoma. Is that correct?
I mean, we've started a protocol probably like 3 years ago, and we've transplanted 2 patients so far.
So 1 year is fair. So how come then that I work in a small center, Rotterdam, the Netherlands. In 1 year, I do about 20 pumps for advanced intrahepatic cholangiocarcinoma. Small center, small country. So the point I'm making is that I think there's an analogy with transplant for colorectal liver mets and transplant for intrahepatic cholangiocarcinoma, that it may be a good treatment, but for a very small proportion of the entire population. All those other patients you can give a pump. And I mean, I also do transplant. I love transplant, but I think it's good to realize that if you have 100 patients with advanced intrahepatic cholangiocarcinoma, probably 95 are eligible for pump. We have many octogenarians in our pump program. And maybe out of those 100, 1 will get a liver transplant, maybe 2. Is that fair?
I mean, I think it's fair, but you're talking about a different population. We're not going to transplant an octogenarian. You're saying you're putting a pump.
I thought the population I want to talk about is patients with liver-confined, unresectable intrahepatic cholangio.
No, that's
the point I'm making is that they almost all can get a pump. And only a tiny fraction. That's not to say that it may not be a good strategy. It's just, if you want to look at the big picture, it's good to realize it's a highly selected group.
Absolutely, but I don't think anyone is arguing differently. I think this is for a highly selected population, especially now that we're still learning. So I agree entirely with you that this is for a small population. Now that every patient needs a pump, I don't know if I agree. I don't think we have the data to say that every patient with intrahepatic cholangiocarcinoma needs a pump.
I was talking about the unresectable setting, but
no, I know. I mean that I don't know if every patient with intrahepatic cholangiocarcinoma unresectable needs a pump. I don't know if I agree with that statement. I'm just saying that this is for sure for a small population.
Especially in the age of targeted agents.
Yeah.
I mean, Seb, can you comment on one question I had when you were during your talk was, do you think differently about advanced intrahepatic cholangio, big bulky tumor versus kind of the, multiple bilobar nodules, intrahepatic cholangio we occasionally see? And do you think one is better for the pump? I always there's this theoretical argument that the pump may not be as good for kind of one single large tumor in terms of downstaging or treatment, but I don't know that we have any data to show that.
Yeah, I was going to say, I think that's just probably what we feel based on like anecdotal, but really the data is very truly unclear.
Right.
And I think the point here, and I think Boss made a good point, is that it's similar to, the colorectal liver met sort of situation where we need to really figure out an algorithm and find out like where does transplant fall within the algorithm of the pump and other sort of local regional therapies. And there's so many new trials that are coming out with systemic plus, Y90, systemic this, and even, so I think in fact, I think we knew a lot less than we probably knew a year ago. So I think now the box has just like become much more challenging. And I would say the one other thing is like, I don't think we should do these things off protocol, right? To say that we don't have we don't have enough prospective data, or this is a challenging thing to do. I mean, I showed you that, yes, the trials for targeted therapies, I mean, 50 centers, right? Those are like, it's a lot of effort, but it doesn't mean that we shouldn't try to do this on trials so that we can actually learn, because otherwise we'll be in the same space here in 5 years discussing that we only have retrospective selected patients and then not know how to move forward. So
great point. Yes, sir.
Yeah, Martin Deep from Chile. Thanks for an excellent session. So I think that the utilization of deceased donor or living donor for higher risk cancer patients, I think it really depends on the donation rate and the mortality for each region. So our mortality on the wait list is 35 to 40% mortality on the wait list. And so that's why we need to do more live donors, unfortunately, because if we had more donors, we didn't need to. So I think in our country, for example, using deceased donor for a patient that has less survival, 5-year survival, I think is prohibited. So what I want to ask the panel is, have you thought about a number or a threshold to say, okay, in this region, for example, this is X% mortality on the wait list or X donation rate that will justify using using a deceased donor for a higher risk recipient? Like, it would be nice to have that threshold for each region, so that way we, in the community, we know, like, okay, we have enough donors, so that way we can push the boundaries on the recipient. I don't know if anybody has done that exercise. Thank you.
Angie's your UO1 grant right here.
Well, I would say that what Dr. Chapman talked about earlier is probably the first step to the approach. So instead of saying that we have a threshold for all deceased donors, do we have a threshold for utilization of deceased donors that would not otherwise be used? And I think that that's where you can push the boundaries. And you're not, and what it changes is that you're not necessarily taking a liver that would otherwise be used for somebody else out of the pool. And that's always where we get into these debates about utility and about justice and fair distribution, is that this liver could be used for these 5 patients. We've got to make the best use out of this particular liver. But when you get into the discarded livers, this liver is not going to be used for anyone. If it's a usable liver, can I use it for this patient who is marginal? And then when you start to develop, like, these patients are doing well, and you've got better data to support the utilization of grafts for extended indications, then you can move into where they're appropriately distributed.
I think if I can add something quickly, and Wellington mentioned it briefly. I mean, I think on the other hand, there's a bit of a, it's a bit, and we get to these discussions with our hepatologists all the time. I don't think anyone, or maybe you guys argue, but to transplant a 69-year-old patient with a BMI of 52, cardiovascular disease, there's a lot of pushing the envelope in a lot of indications, and then we bring, a young patient with, cholangiocarcinoma, and everyone is saying, well, you guys are crazy, what are we going to do? So I think we need to look a little bit into that, and, going to Wellington's point, we're looking at, SRTR data, European data put together and comparing cancer indications with some of these, fourth retransplant, high BMIs, and the outcomes are probably better on the patients with malignancies. So I think we need to take that into account.
Did you want to comment, Wellington?
Yeah, I like to comment there, Martin's comment that this is not going to impact your waiting list. Maybe we can try, and in very select patients, we can reach maybe more than 70% survival. So we have to start. I think this is my point.
Okay. Deniz Balcı from Istanbul. Well, coming from about 10,000 kilometers away and completely understanding the different logistics and the way we look at what we're doing, it's still surprising for me that I come to America's HPB surgery meeting or oncology meeting. So my point is, we are talking about, echoing my colleague here in Rotterdam, we are talking about a very small fraction of patients, and the highest volume liver transplant surgery centers in the United States are probably, or North America is represented here some way. And we're still looking at a very small fraction of patients that we're talking about. What about the majority of these cohort? And when we have the advanced liver surgery options going on and on every day, we're not discussing in detail, because I'm not because, but we have an upcoming paper in Surgery Journal that is a multi-continental paper saying ALPS procedure for perihilar cholangiocarcinoma is approaching about 50% 5-year survival. A procedure once considered a contraindication for the given indication. And it's very difficult where I come from to imagine to find patients that are 2 centimeters, intrahepatic cholangiocarcinoma is not resectable, or 3 centimeters. How do you explain that? So I would like to ask the panel. Thank you.
I'm happy to tackle that. So I mean, I think the patients, so I agree with you about the population we're looking at. However, I would say that this is a start, right? We need to start with, restricted criteria. I think in the 10 years, and now what I'm saying is completely wishful thinking, but I think with new therapies, new things coming out of the pipeline, maybe Compass Bridge, et cetera, we may be expanding that population, but we're starting small. In terms of the small cholangios in cirrhotics, I'm always talking about patients that have decompensated cirrhotics and are not resectable. Like a patient that's resectable, I would argue that should not have a liver transplant, should be resected. I don't think I don't have any discussion about that.
Yeah. Thank you.
Dr. Cato, I had a case I wanted you to comment on, so I'm glad you're here.
It's just the question and comment. I think, what we are really talking about here is much more towards the locally advanced cholangio, intrahepatic cholangio, how we're going to do with the transplant. I think the cirrhotic and 2 centimeter, 3 centimeter intrahepatic cholangio is probably no-brainer. That's something that we are going to take on as a transplant candidate. So, and then looking at this Houston Methodist data and also some other comments that I've heard, it seems that we are moving towards doing those locally advanced unresectable cholangio for transplant. And it was pretty much no for all this time until just recently. So I'm just wondering what has really changed and what should be the criteria. We set the criteria in Colombia for at least the disease stability more than a year or 2 as a criteria, because in all the multimodal therapy, intrahepatic cholangio is much better treated. So if it's locally advanced and unresectable, but disease stability, regardless of what modality you use, what therapy you use, for at least more than a year, maybe a good criteria that we saw. But we haven't really seen many patients end up coming to our center and getting transplanted yet. But what do you really think? First of all, what has really changed? Why we are really considering locally advanced intrahepatic cholangio now that we didn't think about it a few years ago? And also, secondly, what should be the most important criteria to go on this new protocol?
Great questions. Sep, you should take a tack with that.
I think I can take a stab at that. And I think what is really different is that we understand the biology and we understand the molecular profiling, and the disease stability is going to be a key player here, right? So you just described, and I think from everything that I've said, and I'm not a transplanter, but that initial sort of space where you give the systemic is really like the key finding. So I think with that, and then I think as a field, we're learning more and more about other diseases, and I think we are being more aggressive in all sorts of different like solitary type of tumors. So I think one is understanding more biology, understanding the systemic, having more systemic options, right? Like even obviously, I think where we were just talking about this here, and it's kind of quietly, is like where does targeted therapy fall into play with systemic? Because clearly the targeted therapies are not first line yet. But that may change, and what order, and really like how long do you wait? The sequencing becomes really the question here. So I think we've had some really incredible advances for cholangio, and that's probably part of the reason that I think the field is shifting.
Yeah, and we just let to Dr. Cato's point. I mean, I think one of the things we need to work as a community. I think the reason, or at least I can speak to Canada, that we're not seeing these patients is because they're not being referred. And I think we need to work very hard with the oncologists, and I think the Cholangiocarcinoma Foundation works very hard in advocating for these patients to go and see some of these centers. I think as we educate oncologists with new therapies, we're actually going to see more patients. I mean, I'm going to maybe put a positive note. I think we're starting very small, but in the next 10 years, if all the things that are coming and the oncologists are, encouraged to a patient that's stable, because I think they need to be stable for 9 months or a year, as you mentioned, and they refer the patients, we're going to see more of these patients in the next years.
Great. That was a great concluding statement. So thank everybody for being here, and we appreciate it.